Good morning, everyone. I have 8 o'clock, so we'll start. This is Shannon Switkowski. I'm the clinic coordinator of Cardi-OH. We will go around and make some introductions, and I'll start with Dr. Dungan.
Hi, good morning. I'm Kathleen Dungan, an endocrinologist at Ohio State University, and I will be facilitating this session.
Good morning. I'm Dave Aaron. I'm an endocrinologist at the Cleveland VA.
Karen Bailey is our certified diabetes educator from Ohio University. She should be joining shortly. Adam Przinski.
Good morning, I'm Adam Przinski. I'm a sociologist at Metro Health and Case Western Reserve University.
Hi, good morning. I'm Sharon Watts. I'm a nurse practitioner at the VA and a certified diabetes educator as well.
Thank you. Okay, Dr. Dungan, back to you.
Hi, good morning, everyone. Just a few items to review. Our structure, we've got our introduction already complete. As per our previous sessions, we will have a didactic session, about 25 minutes, followed by a question and answer. And please, we ask you if you could just turn on your video and unmute your microphone to participate in the conversation. If you need to, you can put questions also in the chat box. And then that will be followed by our case study presentation, which will be about another 25 minutes. And don't forget at the end to complete your post-clinic survey. And with that, we will move on. This is Cardi-OH tackling type 2 diabetes. These are our disclosure statements, and these were also emailed to you as part of the presentation. Next slide. And so our presentation today is on advanced diabetes care models. Sharon Watts and Elizabeth Beverly will be presenting these today. Sharon and Elizabeth, would you kindly introduce yourselves and take it away?
Okay, thanks, Catherine. So I am a nurse practitioner at the VA for the past 20 years, working exclusively in endocrinology, diabetes, trying to improve care, and I also work part-time for central office for the past 11 years as the diabetes advisor for the VA nationwide in nursing. And Liz, are you on?
Hi, everyone. Yep, I'm on. Good morning. I'm Liz Beverly. I'm at Ohio University Heritage College of Osteopathic Medicine. I'm a behaviorist, so I specialize in diabetes research from the behavioral and psychosocial perspective. And yeah, so Sharon's going to be talking most of the time for this because she is the expert, and I'll just chime in at the very end. So take it away, Sharon. Thank you.
Okay, thank you. And thank you for the organizers for inviting us to speak. This has been my passion for the past 20 years, trying to improve diabetes care at the VA. And here are our objectives. Okay, and it's not, oh, there it is. So we are going to talk about different models of care and some of the things that I've learned over the years. And that I think a lot of times primary care is not clear on. And the first would be in endocrinology, we always get very creative in trying to involve nutrition for our patients. So it is there's a robust amount of data that shows if you can get your patient to the nutritionist, the registered dietitian, who is knowledgeable about diabetes. Our dietitians that we refer to are certified diabetes educators as well. And there's a lot of data to show they can help you with consistent carb diets with your patients. Mediterranean diet has a lot of good data for patients with diabetes and prediabetes. They screen for food insecurity, which can cause hypoglycemia in patients with diabetes. And they assist with overall general education. So I know when I'm sending my patients to a dietitian, they're going to address hypoglycemia as another backup mechanism for me, safety-wise, in treating these patients with diabetes. So if we'll go back, I don't know why there are gremlins, but there are today. Most of my patients will say, all right, I give up. They don't want to see a dietitian because they think they're just going to be told to lose weight. And as we all know, losing weight as you get older gets incredibly hard to do. I really convinced them, no, these dietitians are working with me to help get your blood sugars more stable. And if you send someone for medical nutrition therapy, there is a robust 1 to 2% lowering of A1C. You can't beat that with a drug. So we often withhold, very kindly withhold our continuous glucose monitors. You have to see the registered dietitian, who's our certified diabetes educators, in order to get the CGMs, because we want people to know about carb counting if you're at the point where you need a CGM. So it works beautifully, and it's been a great deal. We'll go to the next slide. So the other thing in working with, teams model is getting your patient to a diabetes self-management education class. So I'm not talking about just one-on-one teaching about diabetes in clinic. These are classes that are certified through 2 national certifying bodies. Certified diabetes educators who know what they're doing teach these classes. And the data is coming in on a lot of good outcomes for these classes. So the classes are interactive and they help patients look at barriers to care. It has to be taught by a dietitian and a nurse and or a PharmD. And it's kind of a backdoor way for you to get your patients to meet these other providers who can spend the time that you as a provider in the clinic can't, in working through some of the issues and barriers that they have in diabetes care. So if we go to the next slide, I've listed out some of the data that shows why you really want to send your patients to the dietitian for medical nutrition therapy or to diabetes self-management education classes. So if you look at things like reduce hospital admissions and readmissions just by going to diabetes class, that's a win-win. We improve A1C, seeing both of these folks. There's improved quality of life. Patients, we get really good responses in our evaluations from patients when they're seen by these. They're just, reduce diabetes distress, reduce hypoglycemia. So it's an added layer of benefit for you as a provider to know that your patient is well educated how to handle hypoglycemia. They learn healthy coping, depressive symptoms are reduced. So that's DSME. And then if you would look at the benefits, similar benefits with medical nutrition therapy, they cover a whole lot more than the average person thinks that they cover. Decrease in diabetes distress, again, cost savings, hospital admissions, again, for medical nutrition therapy. So just hands down, win-win situation. So if you're not already sending your patients to these services in your areas, think twice, and I put the data in there for you to look at. Okay, we'll go to the next slide. So there's a lot of research, and years ago I did a systematic review of of case management, nurse case management interventions in diabetes, and there's a lot of good data for nurse case managers. Although you cannot take a nurse from a primary care clinic, train them for one day in diabetes, and think you're going to get good outcomes. Most of the studies show that we need to have qualified, healthcare providers giving interventions, and then you'll see some good outcomes. So this is just an example where, a lot of our patients, we have difficulty with med adherence. And I know we don't always like the word adherence, but barriers to care, perhaps, taking medications. And so it was a 12-week study. It was a research study. And these case managers in this, care managers, they called them. The article never really said what their background was, besides the fact that one had a bachelor's degree and one had a master's degree. They were research assistants. But the significance is, if you take, they said at the beginning, 37% of the sample were adherent, but even that adherent group missed some of their doses. At baseline, what they considered adherent was taking 72% of your meds. But with this intervention, they increased that up to 100. The second group showed, some more difficulty taking their medication, but and they would only take 30% at baseline, but that even was increased to 80% by the end. And then probably significant to note is that there always will be a certain percentage of people who just won't be able to take their medication. It's not the right time for them. And Liz, I know we will talk about that later, but that's a personal, adult, individual decision, and we can only do our best, But the idea here is that they had 30-minute in-person sessions, baseline 6 weeks, 12 weeks, and then some phone visits in between. So it's multiple touch points, looking at what are the barriers to care, trying to resolve those, and working with the patient. So, any intervention you use besides your one-on-one provider visit will help augment care. So whether it's a diabetes education class, a medical nutrition therapist, maybe you have some case managers at your clinic. There's a lot of data on pharmacists as case managers and good outcomes with that as well. So utilize any resources you have at hand, and you're probably going to get more bang for your buck. So we'll look at the next slide. I was asked to speak a little bit about shared medical appointments. Of course, this was pre-COVID when we were looking at this curriculum. And I published a bit on shared medical appointments. I love shared medical appointments. It's a great model. It's just not going to fit right now with COVID. So the VA, that's okay, you can stay here. The previous slide was just a link where you can go, and it's outside of the VA firewall. And you can see the shared medical appointment manual that we've created. We've updated it over the years, and given you, as much as we can think to help you with, if you're interested sometime in the future, when COVID is not looming around us and you can safely get patients in a room together. Shared medical appointments are great. Our patients absolutely love them. It helps with access. Someone will call and say, hey, I got a guy with an A1C of 16. Can you get into your shared medical appointment tomorrow? Sure, we just fit them right in. We have improved patient outcomes. We reserve our shared medical appointments for people who fail everything else. They fail, one-on-one with their primary care provider. They've already gone to diabetes class. They've already seen nutrition. So our shared medical appointments are run by our health psychologists and our dietitians. There are a lot of healthcare professionals in the room at the time. So, you know, people always question the cost of these, but remember, these are the patients that are really that 34% in the previous slide who are falling through the cracks. So we are really addressing that population who are going to get into trouble if we can't get their A1Cs down. So next slide. So the benefits for the staff, I mean, the patients love the SMAs, and I will tell you, even the patients who grumble and are mad and say, why am I in here? And, you know, we work with them, honest to goodness, they're always the patients that we can't get out of the SMA. Once their A1C is fixed, they don't want to leave. So, okay, we say come back in 6 months, you know. So there is a lot of support for patients with each other. They share stories, they share barriers, but as well for the staff, there's a lot of camaraderie, supportive environment, and sharing of expertise. So honestly, I can do motivational interviewing a lot better now just from having been in these shared medical appointments every Thursday morning. And I know a lot more about nutrition, and it's just been a great benefit. We have pharmacists in our shared medical appointment as well. So you can go to the next slide. So for our patients, one of the, you know, there often are a lot of mental health barriers to, you know, for our very difficult to control patients. And often they will say, no, I won't see, I won't let you give me a referral to mental health. But if our health psychologist is there running the group, it's a warm handoff, if you will. They see that this person is not, you know, a terrible person to meet with. Same with nutrition. You know, if they've said, no, you can't give me a referral to nutrition, but that nutritionist is right there in the group and they take the patient aside and work on with them one-on-one, we seem to get a lot better results. So the patients, you know, hands down, they love talking to each other and they gain a sense of control, and there's a high patient satisfaction from our shared medical appointments. Next one. So here I've just kind of given you a column to show the difference. When we have trainees come in, they are misunderstood. They think our shared medical appointment is a class. It is not. We offer plenty of diabetes classes at the VA. Shared medical appointments, the purpose is just to get at the barriers to care. So these are high-risk patients. It's discussion the entire time. The only thing we ask is that there is a discussion on hypoglycemia and how to treat it because of safety issues. But other than that, we do not want to discuss foot care or whatever, unless the patient brings it up. But it is barriers to care, living with diabetes, you know, asking patients what has helped them, maybe to share with someone else. So it's lively, great discussion. Okay, next slide. I was also asked to talk a little bit about the SHARE approach. So Agency for Healthcare Research and Quality. And there is plenty of data that diabetes, you know, as a chronic disease, most of it is done at home by the patient and they have just a small snippet of time with you. So unless you negotiate and work with them on what will work for their care, ask about their values and preferences, compare treatment options, you know, so give them here's what drugs we could use, here's the side effects, here's, you know, what do you think would work with you? in the long run, it seems like a lot of time spent discussing this, but if the patient is not gonna, stick with the plan, it's a wasted visit anyway. So I do a lot of talking with patients and, asking them, they say, well, I'd rather try getting rid of my sodas every day. Well, on a scale of 1 to 10, how likely do you think that will happen? And so, and if that's their choice, that's their choice, but we'll revisit it next time. So a shared model and approach is ultimately what's going to work for the patient in the long run. So next slide. We were also asked to talk a little bit about joy at work. And this is a fun topic to discuss. And I have written a few manuscripts on this. Joy is important to avoid burnout. Work satisfaction, it seems like there's 4 key components to work satisfaction. One is having, feeling a sense of safety at work. Oh, shoot, sorry. Having a sense of choice and autonomy, camaraderie, and we talked about shared medical appointments as offering camaraderie. Even QI projects, what you guys are all doing now, offers camaraderie and teamwork. And we know that joy at work affects patient safety, care, and organizational performance. One of the things the VA currently is doing, instead of waiting for people to leave their job and do an exit interview, they are now doing retention interviews. What would keep you at this current job? What makes you happy? What doesn't? I think that's a novel idea. And then the last thing I'll speak about is that there is an article on patients with diabetes. Providers who take care of patients with diabetes, they gave them the same diabetes distress scale that they give to patients. And lo and behold, this was across all healthcare workers, physicians, CDEs, nurses, and guess what? They found that as providers, we experience diabetes distress. Watching and working with our patients with the frustrations of lack of treatment adherence or barriers to treatment. We worry about poor outcomes. We worry about those kidneys going south. And we feel overwhelmed by all the social needs of these patients and trying to get some purpose and meaning to improve their care can be tough. So with that, I will hand it over to Liz to help us with more joy at work.
Thank you, Sharon. That was a wonderful presentation. So Rick, you can just move on to the next. Thank you. So I'm just going to build a little bit. This is all I'm going to say is this one slide. So talking about joy of work, I think it's really important, that last point that Sharon brought up about the diabetes distress. So we know that burnout is a major issue with healthcare providers, and there are estimates of approximately 50% of providers, and this is all providers experiencing some occupational dysphoria. And it's not just an issue with healthcare providers, although healthcare providers do experience the highest rates of distress. But now that work from Mary DeGroot at Indiana University School of Medicine showing that not only do patients experience diabetes distress, but now this is some of the first work coming out that shows that providers also, and it's all providers who work with patients with diabetes, are also experiencing the similar distress, is really important, because I'm sure what she's going to be doing is showing some of that work that this diabetes specific distress from the provider perspective is also going to contribute to burnout later on. So what are some things that we can do about that? Well, ways to stave off some burnout or things to address burnout is to promote this joy of work. And here's some of the things that you can do for addressing joy at work. Well, there are interventions out there. Just a couple of examples. You have appreciative inquiry. I just want to highlight that appreciative inquiry is something that was developed by researchers at Case Western. And what appreciative inquiry is really focusing on is it's a strengths-based approach. So a lot of times we think of, okay, things are not going well, I'm exhausted, and keep in mind, I'm not a clinician, I'm a researcher. I do study burnout, but I can't really speak to what it would be like life in the clinic. But I can imagine things are very, very stressful and not everything is maybe as efficient with everything going on with COVID. And so you might see the problems and want to address the problems. Appreciative inquiry addresses it from a strengths-based approach, where you're taking things by focusing on what's the best and most essential and effective things that are working at your practice and approaching it that way. And you do from these, it's called the 4D cycle, where you're looking at things from as a collective effort with everyone who's at your clinic as a healthcare team, focusing on the best things. So what you're doing together is you're trying to dream about the things that as a group you want to move forward to, rather than just focusing on the negative critical things about your practice. A lot of times the interventions, the ones that are most successful, are organizational, because if you can change things at the organizational level, you can have the most effective outcomes. And then the other thing to do is to individually target your own meaning of work and what does work mean to you. Some of the things that have also been shown to address, I would also say, that I understand that some of these things may be on your ability to change, for example, the work hours and limiting your work hours. Offering flexible work arrangements. It's interesting right now in the time of COVID with limiting work hours and flexible work arrangements. It's interesting because, for example, a lot of us are working from home right now. So the flexibility is there. At the same time, if you're like me, you're also working from home and working at all hours because you're also maybe taking care of a young child at home. So I think things are very blurry right now during this time, even though we've been working in this COVID time for the past 7 months. But I think this, at the same time, we're going to be doing this for the foreseeable future. So finding a way where you can limit and set boundaries with your work hours while still adhering to what you need to do to maintain your own current job and not lose your job, but at the same time, having that your employment where they can be as flexible as possible. Some of the other things that have been shown is if you can have leadership training, and ideally this would be leadership training that's covered by your employer. And what this is leadership training gives you empowerment, and the empowerment allows you to then have the self-efficacy to act on the things that you want for yourself. And it can also help you to dream as to what you want for the future and help see that through. The same thing along those lines with leadership training is you'll see the same thing with communication skills training. A lot of times, some of our problems that we're having are communication issues. And when you have effective communication skills training, you're better able to speak on your behalf about what it is that you want. At the same time as ask for what you want, but you're doing it in a professional manner. Things that prioritize teamwork and relationships. And this is something that Sharon just talked about, and the importance of having collegiality. So things when you prioritize the team and getting along with your team and relationships with your patient, this will improve joy at work. And then, of course, we all go through difficult times. And if you're a provider and you are struggling, it's important to seek help and to not feel stigmatized, or to not stigmatize others if they need help. And then one of the last things, if you do feel that you're struggling or see someone else struggling, or if you just want to promote joy of work at your own office, there are surveys that are written for joy of work, and they're very important to give them out periodically, just as an assessment for baseline and just to see how things are going over time. And it can even be a nice check for you personally, just to see what is important to you and what matters and where you are, because things do change over time. And so these wellness surveys, which I can have Shannon send out later via an email, they're just really nice reminders of what's important to you. And things do change over time. So I do think it's very important that you personally, if some of these things are beyond your control, is just to assess where you are at with your own joy of work.
Well, thank you very much, Sharon and Liz. That was a really great discussion. And I do want to open this session up for questions. So please feel free to turn on your video cameras if they're not already on, and unmute your microphone while you're speaking. But then when you're not speaking, you can still mute it. And if you'd like, you can send us some chat messages in the chat box. And then there's there are a couple of comments here. Dave Aaron suggested checking out an online course called Inspiring Leadership Through Emotional Intelligence. There is a link to that in the chat.
Good morning, everyone. It was a great presentation. I really liked the part by Liz at the end, especially. So I have multiple roles, and in addition to doing research and being here, I'm actually Chief Clinician Experience Officer for University Hospitals Health System, which is an executive role. And we went about that role quite systematically to find out what our providers, which includes advanced practice providers and physicians, really want. And after hundreds of surveys, it distills down to three things, and this resonates with what Liz said. They want to feel rewarded for looking after at least one patient correctly. They want some sort of, victory, for lack of a better term, a hemoglobin A1C that gets into the normal range, or someone who's lost weight, or someone whose blood pressure is under control, just once a day. The second thing they want is to be valued for their contributions outside of clinical care, because we're an academic health system. So for their teaching or for their research. And the third thing they want is they want to make it home at a decent hour, which was reported at between 6:30 and 7 p.m. at the latest. So I think that as long as we keep that in mind, it's very important. And while individual approaches to joy of work are well and good, I think it's our imperative to lobby for those sorts of changes so the system actually works to our benefit as well. Thanks.
Great. There's another comment from Chris Taylor. From our research in the linking primary care patients to registered dietitians, patients' comments were that eating well was something they know they should do, but it wasn't real or important until their doctor told them it was a priority. One of the questions or feedback that I've experienced recently from our diabetes educators, and maybe this is coming out more because we're in a virtual world, is that as they're trying to schedule education now, the patients didn't even know that they had been referred. How do you make that a priority in your visit, and how do you communicate to the patients? Because I think that is a big barrier, is getting patients to understand how important it is, that it's not just, okay, I already know what I'm supposed to do, but I just don't do it.
So Kathleen, this is Sharon. I'll just address a little bit of what I think you're saying. When we do a referral for diabetes self-management education or the nutritionist, we're always asked, did you discuss this with the patient? And I never put in a referral unless the patient says yes. I explain to them, this will keep you safer from hypoglycemia, working with the dietitian or going to this class. And bring your family if you like. We bring all family members to all visits, and two heads are better than one when it comes to setting up a meal plan. And sometimes I have picked up the phone and called a patient afterwards and said, you missed your appointment, would you like to reschedule? Because it'll come back to me that they were no-show.
The one comment I would add is just that from a disparities perspective, some of my own work and that of others using national data has shown that low-income persons and racial and ethnic minorities, particularly language minorities like Hispanics, are less likely to participate in diabetes self-management programs, in shared medical appointments, and other forms of sort of peer support. The other part of that is that the same studies typically show that those patients who are of low income or are racial and ethnic minorities are also those who are most likely to get the most benefit from those visits, so that they actually, so that the data shows that despite being less likely to participate, when they do participate, they're likely to get even more benefit than the people who typically participate in those visits. So there's a really strong warrant for these additional conversations of really sort of working through and building the trust and figuring out what the barriers are to someone participating in those sorts of visits, because they can have such a tremendous impact on diabetes control.
This is Sharon. I would just make a comment to that. One of the things that we have done is brought our dietitians and CDEs into the clinic, into endocrine clinic with us. And so they have some flexibility when I have a patient who really needs to see them. They usually don't say no. I say, Neil's across the hall. I'd like him to, work with you on a little bit of get started on a little bit about diet. When that works, it's great.
Yeah, we've done that too, and I think that's really helpful, especially when you've got a patient who just has so many barriers, and you just need to kind of get them, engaged right there at the moment.
Question from Five Rivers. Have you used telemedicine for the group visits? I know there's some resource challenges, but I wonder if that has been successful in maybe improving adherence to those visits and how the patients react to them.
We have not, Five Rivers. It's just been too difficult. That our population that we invite to the shared medical appointment are very difficult to control, and we didn't think it was going to work by Zoom. However, we do have other shared medical appointments within the Northeast Ohio. Youngstown has just an insulin titration shared medical appointment, or Parma has just type 1 diabetes shared medical appointment. I could see where it might work more for them, but ours were the more difficult to control.
Sort of an intermediate step beyond that. A friend of mine at the Providence VA has organized group visits. In his case, it was for heart failure, where the expert group was in Providence and the patients were in Guam. So doing it remotely, and we're trying to organize virtual shared medical appointments for heart failure right now, but we haven't done it with diabetes. And I see that Shari has some positive experiences from doing it virtually.
Yeah, we haven't, I don't lead those group visits, but I know that at Metro Health, we've done several different types of group visits virtually, our diabetes prevention program, as well as our diabetes group visits. And those are in low income safety net populations, and they've been able to do them. But I don't know, I know there were barriers and challenges in getting those started virtually, but they have been able to do them. I just can't speak to the challenges or benefits that they've seen with that approach.
Great. Well, I think we'll move on to our case study presentation. If we have some more time at the end, we can take on some additional discussions. I guess I'm curious if the patient says that he is checking his glucoses. I'm assuming you don't have any data, like a glucose log.
Yeah, so we have, exactly. We have had a lot of difficulty having him bring in like written logs or objective data for us to work off of, but a lot of it is very much subjective in terms of what he's reporting to us that his readings are.
And does he have any kind of motivating factors or things, what is important to him as far as goals?
I think his children are his primary kind of motivation, and will to care for himself. Although I think caring for 3 mentally disabled kids poses its own barriers in terms of time management, and responsibility allocation. So
yeah, so there are a couple of different things. I mean, just at the top of my head, I would think that we'd want to address the mental health, and that nothing else is going to get better until, you know, if he's really severely depressed, that would be kind of the first issue to address. Anybody have any anybody have any thoughts on that?
So this is Sharon. I would say check a TSH, C-peptide with glucose that has to be over 180 at the same time. And GAD, could this guy be LADA? His BMI is 25 and had DKA. And if he is, you know, in multiple hypoglycemia, I don't know how low. You said he has lots of lows, but we would get someone like him an easy to use CGM, maybe the Libre 2, you know, as soon as it gets the app that you can download the blood sugars.
Yeah, I think you raise a great point there. No matter what the age, I guess, you know, maybe you'd want to dive into, does he have a family history? But either way, if I would make sure it's not type 1 diabetes. In anybody who has, you know, who's diagnosed at a reasonably young age, anyone who's young, you'll find it a lot more. You'll be very surprised how often you find it.
Yep. And if it is LADA, late onset or type 1, you know, we can avoid the hypoglycemia by doing 40% basal and 60% bolus. I mean, that just helps getting away from that hypoglycemia. They're over basalized usually.
Mm-hmm.
This is Dave. I would think about this less as a case of diabetes and more as a case of a major imbalance between the management burden and the capacity to deal with that burden. And I guess the first question I would ask is, are there other resources that could be brought into play to reduce the management burden? And when I talk about management burden, I'm thinking not only management of his illness, but management of his children and everything else that that surrounds that. Because if you can increase this fellow's capacity to manage his own, or I shouldn't say if, increasing his capacity to manage his own condition is a prerequisite to managing that condition well. It may be like Dr. Dungan suggested, focusing on mental health, but maybe there are some community resources to help with his children. Sounds like he could use a little respite care, frankly.
Mm-hmm. Yeah, this sounds very challenging.
Yeah, one other thing. Remember, all during this, take care of yourself, because this is exactly the kind of patient that can frustrate the crap out of you.
Talk about diabetes distress for the caregiver, right?
Yeah.
Mm-hmm.
Yeah, I definitely think that we've over the years tried to get our kind of social team involved, behavioral health involved. Unfortunately, I think a lot of non-compliance with showing up for appointments and things like that has been a limiting factor in a lot of what we're doing, which is naturally kind of frustrating, but we're still trying to continue to open those resources up for him. Our goal is kind of to find resources in the area that can, like you said, assist with the child as he's supporting these children. Because I think that's definitely a primary barrier for him in terms of being able to come to appointments or routinely be involved in his care on a daily basis.
Remember that if there were a simple solution to this, word would have gotten around by now.
Can you guys hear me? This is Karen.
Hi, Karen.
Oh, finally. I'm on my phone and I have been trying to talk and I could not unmute myself, and I finally did it. With this situation, I agree that I would feel as a diabetes educator completely overwhelmed by this poor fellow's situation, and put myself in that position. You know, as a caretaker, you put your health last because you're just trying to push through and take care of your family. So I think I'd be calling around maybe, and I wonder whether the psychologist or psychiatrist that he sees would know about linkages to community support for mental health patients. I would probably contact the local health department and see if they have any programs or grants to help, families in need. But definitely, if he doesn't get support, there's no way he can take care of himself because he's obviously overwhelmed by his situation.
Yeah, and there's a couple of great suggestions in the chat. Jim Warner suggested the community psychiatric supportive treatment, case management to provide support for patients with autism. So for his kids, services available from home and community. On the other hand, on the side of the management, there were a couple questions about if he's had some antibodies. It doesn't sound like that's the case yet.
So no, he at a time of original diagnosis, which was many years ago, I believe 2010, he had a C-peptide level checked, which is what led to the diagnosis of type 2 diabetes. We were thinking about getting antibodies checked when I last saw him for the first time about a month or so ago. So yeah, that was definitely part of kind of the thought. It doesn't sound like I'm seeing about sleep apnea. It doesn't sound like he's having symptoms necessarily associated with sleep apnea, but it's something definitely we can look into because he does have like this daytime fatigue, which is likely related to his kind of overall diabetes picture. But it's certainly something we will look into.
And another, Roseanne asked, do you think this would meet criteria for mandatory reporting on the welfare of the children if he's not caring for himself and you think he might be, I guess, assuming if you think he might be suicidal?
Yeah, that's definitely something to consider. It sounds like from when he says he does spend a lot of time with the kids, even with all the COVID stuff going on, he's largely unavailable during the days because he's at school with his kids or spending time with them. So I'm not getting those immediate concerns right off the bat, but it's definitely something we should look into as far as is he actually caring for the kids adequately as well. And then I saw another question from Ms. Sherry Bolin, but yes, we have been able to reach him via telehealth. Yes, so that has helped definitely.
This is Karen. I have a question. Would you be contacting maybe his psychiatrist and seeing whether kind of like coordinate care? Maybe the psychiatrist has been dealing with some of these issues too already.
Yeah, so he actually last saw the psychiatrist. It was almost, I think it was in 2019, but he had a follow-up appointment. Looks like he got lost to follow up with the psychiatrist. So it's just been maintained on his medications. He had been on SSRIs and SNRIs, but I think he just kind of stopped those because he didn't think they were helping. So we're trying to reconnect him with the behavioral health team after his most recent hospitalization.
Okay, well, we are at the top of the hour. Thank you, everyone, for your great comments and discussion and the great case today. With that, I would like to turn it over for our wrap-up. Shannon?
Yep, thanks, Kathleen. Please register on our website if you wish to watch recorded clinics. Rick has them up every week. And next, if you would please complete your survey, you should have received this morning by 5 tomorrow. And also at the end of our series, we will offer CME credits and instructions on how to claim those. Next week, we will have type 2 diabetes in the context of cardiovascular risk with Dr. Kendi White-Solaro and Dr. Jim Werner from Case Western Reserve University. So have a happy Halloween this week. Be safe and stay well. See you next week. Bye, everyone. Thanks for coming.
Thank you.
Bye-bye.
Bye-bye.
Hang in there.